You open your pill organizer every morning. One medication for blood pressure, another for cholesterol, maybe something for acid reflux, a baby aspirin, perhaps a painkiller for arthritis. And you swallow them all together with a glass of water because that's what you've been doing for years, maybe decades, and nobody has ever told you otherwise. The bottles get refilled, the routine continues, and somewhere in that handful of pills you take every day without a second thought, there's a combination sitting there that's silently dangerous. Not tomorrow, not in theory, right now. And here's what should genuinely make you angry. The pharmacy that fills your prescriptions has a computer system that's supposed to flag dangerous drug interactions. Your doctor has access to your full medication list. And yet, these combinations slip through all the time because the alerts get ignored, because you see multiple doctors who don't talk to each other, or because you're taking over-the-counter medications that nobody knows about because you didn't think they mattered enough to mention. And by the time the problem shows up, by the time you end up dizzy, confused, bleeding, or in the hospital with kidney failure, it's too late to prevent it. You're managing damage that never should have happened. But before you panic and before you stop taking anything, let me give you the critical piece of hope you need to hear. Most medication combinations are safe. Most of what you're taking is probably fine. But there are specific pairs, specific combinations that after age 60 become genuinely dangerous because of how your body has changed. Your liver processes drugs more slowly. Your kidneys clear medications less efficiently. You carry less water in your body, so drug concentrations run higher. And you're more sensitive to side effects that a younger person's body would shrug off. That means two pills that might be perfectly safe in a 40-year-old can create a crisis in a 70-year-old. Same pills, different body, completely different outcome. In my years of practice, I have seen this exact scenario play out more times than I can count. A sharp, careful older adult comes in feeling awful, weak, confused, dizzy, sometimes bleeding from somewhere they shouldn't be. And when I pull up their medication list and actually read through it line by line, there it is. Two medications that should never have been prescribed together, sitting side by side, sometimes for years, and nobody caught it. We stop one, we adjust the other, and within days or weeks they feel like themselves again. Same person, same age, different information, different outcome. So before I show you the two most dangerous combinations, do me a quick favor. If you want videos that actually protect you from the things your doctors don't have time to explain, hit subscribe, give this a like, and leave me a comment listing every medication you're currently taking, including over-the-counter ones. I read those comments, and sometimes I catch combinations in there that need attention. Your 15-minute doctor's appointment isn't enough time to catch everything. So let's catch it here. All right? Let's get into it. And I'm going to show you the two most dangerous combinations I see after age 60, explain exactly what they do inside your body, and tell you what to do if you're taking them right now. These aren't theoretical. These are real, common, and happening in medicine cabinets all across the country today. The first dangerous combination is taking a blood thinner, specifically warfarin, together with aspirin or any NSAID painkiller like ibuprofen or naproxen. And I need to be very clear and very specific here, because this combination is incredibly common. It's often prescribed intentionally by doctors who believe the benefit outweighs the risk, but after age 60, and especially after 70, the risk becomes so significant that it deserves a very serious conversation that most people never have. Let me explain what's happening inside your body when you take these together. Warfarin, which you may know by the brand name Coumadin, is a blood thinner. It works by blocking vitamin K, which your body needs to make clotting factors in your liver. With fewer clotting factors, your blood takes longer to clot, which prevents dangerous clots from forming in your heart, your lungs, or your legs. That's life-saving for people with atrial fibrillation, artificial heart valves, or a history of blood clots. But it also means that if you get cut, if you bump yourself, or if you develop any kind of internal bleeding, your blood won't clot the way it should, and a small bleed can quickly become a major bleed. Now add aspirin or an NSAID to that picture. Aspirin works by permanently disabling your platelets, the tiny cells in your blood that stick together to form the initial plug when you're bleeding. One dose of aspirin affects your platelets for their entire 7 to 10-day lifespan. NSAIDs like ibuprofen and naproxen do something similar, though not as permanently. They also block platelet function, and on top of that, they irritate and damage the lining of your stomach and intestines, making you more likely to develop ulcers and gastrointestinal bleeding. So here's what you've created. Warfarin has reduced your clotting factors. Aspirin, or the NSAID, has disabled your platelets, and the NSAID has also made your stomach lining more fragile and prone to bleeding. You've just dismantled two of the three main systems your body uses to stop bleeding. And if something goes wrong, if you develop a nosebleed, if you fall and hit your head, if you develop a stomach ulcer, your body has almost no ability to stop the bleeding on its own. The research on this is overwhelming and frightening. Studies have shown that people over 65 taking warfarin together with aspirin or an NSAID have a dramatically increased risk of major bleeding, particularly gastrointestinal bleeding and bleeding in the brain. One large study found that the combination more than doubled the risk of hospitalization for bleeding compared to taking warfarin alone. Another study specifically in older adults found that those taking warfarin plus an NSAID had a 5-fold increase in the risk of serious gastrointestinal bleeding requiring transfusion or surgery. And here's the part that makes this so dangerous in real life. Many of these bleeding events happen without warning. You don't feel a stomach ulcer forming. You don't feel a slow bleed in your intestines. The first sign is often sudden weakness, dizziness, black tarry stools, or vomiting blood. And by the time those symptoms appear, you've already lost a significant amount of blood and you're in a medical emergency. Now I need to be balanced and honest here. There are some situations where doctors intentionally prescribe warfarin together with aspirin, particularly in people who've had stents placed in their heart arteries or who have both atrial fibrillation and coronary artery disease. In those cases, the combination may genuinely be necessary for a period of time because the risk of a clot is considered higher than the risk of bleeding. But even in those situations, the combination should be temporary, closely monitored, and the doses should be as low as possible. The problem I see over and over is that the combination gets started for a specific reason and then it just continues indefinitely. Nobody revisits it. The aspirin that was added for 3 months after a stent is still being taken 5 years later. Or worse, the patient adds an over-the-counter NSAID on their own for knee pain or a headache, not realizing they're already on a blood thinner, and nobody ever asks them about over-the-counter medications because the question doesn't get asked and the patient doesn't think to mention it. So here's what you need to do if you're on warfarin. First, make a complete list of every single medication and supplement you take, including over-the-counter ones: aspirin, ibuprofen, naproxen, anything. Second, bring that list to your doctor and ask a very direct question. Ask, do I still need to be on both the warfarin and the aspirin, or can we stop one? And if the answer is that you need both, ask how long that needs to continue and what the plan is to reassess it. Third, if you're on warfarin and you have any kind of pain or inflammation that makes you want to reach for ibuprofen or naproxen, do not take it without calling your doctor first. Use acetaminophen instead, which doesn't affect platelets and doesn't damage your stomach lining. It's not as strong for inflammation, but it's far safer. And fourth, if you're on this combination, you need to be vigilant for any signs of bleeding: black or tarry stools, blood in your urine, unexplained bruising, nosebleeds that won't stop, bleeding gums, severe headache. Any of those symptoms mean you call your doctor immediately or go to the emergency room because bleeding on blood thinners can escalate fast. Now let me show you the second dangerous combination, and this one is just as common and in some ways even more insidious because the damage it causes is silent until it's severe. The second dangerous combination is taking a diuretic, a water pill, together with an NSAID painkiller like ibuprofen or naproxen. And if you're also on a blood pressure medication from the ACE inhibitor or ARB family, which many people are, you've created what kidney specialists call the triple whammy, and the risk of kidney damage goes up exponentially. Let me explain the mechanism, because once you understand what's happening inside your kidneys, you'll never look at this combination the same way. Your kidneys need steady blood flow to function. They're fed by small arteries that branch off your main circulation, and those arteries need to stay open and delivering blood at a consistent pressure for your kidney filters to work properly. Your body keeps those arteries open using natural chemicals called prostaglandins. Think of prostaglandins as the hands holding the doors open so blood can flow into the kidney. Now here's what NSAIDs do. Ibuprofen, naproxen, and all the drugs in that family work by blocking prostaglandins. That's how they reduce pain and inflammation, which is great for your sore knee or your aching back. But those same prostaglandins are also holding open the blood vessels feeding your kidneys. When you block them with an NSAID, those vessels constrict. Blood flow to the kidneys drops, and your kidneys suddenly have to try to filter your blood on a reduced supply. In a young person with healthy kidneys and lots of reserve, the body compensates and nothing bad happens. But after 60, your kidneys have already lost filtering capacity just from normal aging. You have less reserve. And if you add a diuretic to the picture, which is pulling water out of your system and reducing your blood volume, you've just made the problem worse. Now your kidneys are trying to function on reduced blood flow and reduced volume at the same time. And if you add an ACE inhibitor or an ARB, which are blood pressure medications that work by relaxing the blood vessels leaving the kidney, you've completed the perfect storm. The NSAID has constricted the vessels going in, the ACE inhibitor has relaxed the vessels going out, and the diuretic has dropped your overall blood volume. Your kidney is now caught in a vice. Blood flow drops sharply, the kidney starts to fail, and your creatinine, the waste product your kidneys are supposed to filter out, starts to climb in your blood. This is called acute kidney injury, and it can happen suddenly, sometimes within days of starting the combination. And the terrifying part is that you don't feel it. Your kidneys don't hurt. They don't send pain signals. The first sign is often just feeling a little more tired, maybe a little nauseous, maybe urinating less. And by the time blood work gets done, your kidney function has already dropped significantly, sometimes to the point where you need hospitalization, IV fluids, and very close monitoring to see if the kidneys will recover. The research on this is not subtle. Multiple studies have shown that the combination of a diuretic, an ACE inhibitor or ARB, and an NSAID dramatically increases the risk of acute kidney injury in older adults. One study found that people taking all three together had more than a threefold increased risk of hospitalization for kidney failure compared to those taking none of them. Another study specifically in people over 65 found that even short-term use of an NSAID while on a diuretic and an ACE inhibitor significantly increased the risk of acute kidney injury, and the risk was highest in people who were dehydrated or had any underlying kidney problems. And here's the problem I see all the time. People are prescribed the diuretic and the blood pressure medication by their doctor, and they take them faithfully. Then they develop knee pain, back pain, or a headache, and they go to the drugstore and buy a bottle of ibuprofen or naproxen because it's over the counter and they assume it's safe. They take it for a few days, maybe a few weeks, and they have no idea they've just created a dangerous combination. Or they mention the pain to their doctor, and the doctor, who's rushed and didn't carefully review the medication list, writes a prescription for an NSAID without realizing the patient is already on a diuretic and an ACE inhibitor. Let me tell you about a patient I'll call Dorothy, because her story is exactly the one I don't want to become yours. Dorothy was 73. She'd been on a diuretic for years for mild swelling and blood pressure control, and she was also on an ACE inhibitor, both prescribed by her cardiologist. One spring, she developed pain in her hip from gardening, and her primary care doctor, who she saw for a quick visit, prescribed naproxen, 500 milligrams twice a day. She took it faithfully for 3 weeks. Then she started feeling off, tired, a little nauseated. Not herself. She assumed it was a virus. A week later, she felt worse. Her daughter brought her to the emergency room. They checked her blood work, and her creatinine, which had been normal at 1.0 a few months earlier, was now 4.2. Her kidneys had shut down. She was in acute kidney failure. She spent 4 days in the hospital on IV fluids. They stopped the naproxen, temporarily held the diuretic and the ACE inhibitor, and watched her closely. Her kidneys slowly started to recover. Her creatinine came back down to 2.1, which was better than 4, but it never went back to normal. She'd lost kidney function permanently because nobody had warned her that those 3 medications together were dangerous, and nobody had caught the combination before the damage was done. She didn't need the naproxen. Acetaminophen would have helped her hip pain enough to get by. Or she could have used ice, physical therapy, and rest. But nobody explained the risk, so she took what was prescribed, and she paid the price. So here's what you need to do if you're on a diuretic. First, check whether you're also on an ACE inhibitor or an ARB. ACE inhibitors have names that end in pril: lisinopril, enalapril, ramipril. ARBs end in sartan, losartan, valsartan, irbesartan. If you're on a diuretic plus one of those, you are already at higher baseline risk for kidney problems and adding an NSAID is the last thing you should do. Second, if you have pain and you need something for it, use acetaminophen, which is Tylenol, not ibuprofen or naproxen. Acetaminophen does not block prostaglandins, does not affect kidney blood flow, and is safe to use with diuretics and blood pressure medications as long as you stay within the recommended dose, which is no more than 3,000 milligrams per day for older adults. Third, on sick days, days when you're vomiting, have diarrhea, or can't keep fluids down, call your doctor and ask whether you should temporarily stop your diuretic and your blood pressure medication until you're rehydrated. Dehydration plus these medications is exactly when acute kidney injury happens most often. This is called having a sick day plan, and every person on a diuretic should have one written down. And fourth, if you do take an NSAID for any reason, even just a few doses, stay very well hydrated, drink water throughout the day, and if you start to feel unusually tired, nauseous, or if you're urinating much less than normal, stop the NSAID immediately and call your doctor. Those are early warning signs of kidney trouble. Now let me add one more combination that deserves an honorable mention because it's becoming more and more common as the population ages. It's the combination of a sedative or sleep medication, things like zolpidem, which is Ambien, or benzodiazepines like lorazepam or diazepam, together with opioid painkillers like oxycodone, hydrocodone, or tramadol. Both of these drug classes suppress your breathing. Both make you drowsy and confused. And when you take them together, especially after age 60 when your body clears them more slowly, the risk of dangerous sedation falls, respiratory depression, and even death goes up sharply. The CDC and the FDA have both issued warnings about this combination, and yet it still gets prescribed, often by different doctors who aren't communicating. One doctor gives you the sleeping pill, another gives you the pain medication, and nobody asks whether you're taking both. If you're on this combination, you need to have a very direct conversation with your doctor about whether both are truly necessary, whether the doses can be lowered, and whether there are safer alternatives. Because this combination has killed people, not in theory, in practice. And the people it kills are often older adults who had no idea they were at risk. Let me pull all of this together, because this is what determines whether you stay safe or whether you become a statistic. Your medication list is not static. It's not set in stone. It should be reviewed regularly, at least once a year, ideally every time something new gets added. And that review needs to include everything: prescription medications, over-the-counter medications, supplements, vitamins, herbal remedies, all of it. Because interactions don't care whether something came from a pharmacy or a health food store. And you cannot assume that your doctors are tracking this for you, because most of the time they're not. If you see a cardiologist, a primary care doctor, and an orthopedist, and each one prescribes something, none of them may know what the others prescribed unless you tell them. The computer systems don't always talk to each other. The pharmacy might catch it, but they might not, especially if you use more than one pharmacy. The responsibility falls to you, and I know that's not fair, but it's reality. So here's your action plan. First, this week, make a complete written list of every medication and supplement you take. Include the name, the dose, how often you take it, and who prescribed it. Keep a copy in your wallet and a copy on your refrigerator. Update it every time something changes. Second, schedule a medication review appointment with your doctor or your pharmacist specifically for the purpose of going through that list and checking for interactions. Don't try to squeeze it into a visit about something else. Make it the focus. And ask directly, are any of these dangerous together? And are there any I don't need anymore? Third, before you take any new medication, whether it's prescribed or over-the-counter, ask your pharmacist to check it against everything you're already taking. Pharmacists are often better at catching interactions than doctors because it's their specialty. Use that resource. Fourth, if you're on warfarin and aspirin, ask your doctor if you still need both. If you're on a diuretic and a blood pressure medication, commit to never taking ibuprofen or naproxen without calling your doctor first. And if you're on a sleeping pill and a pain medication together, ask whether there's a safer way to manage both. And fifth, educate yourself. Don't just swallow what's handed to you. Ask what it's for. Ask how long you'll need it. Ask what the risks are. Ask what it interacts with. Those questions are not rude. They're responsible, and they can save your life. You've trusted the system. You've followed instructions. You've taken what you were told to take. But the system is imperfect, and the instructions are sometimes incomplete or outdated. Your safety depends on you being informed, asking questions, and double-checking what's in that pill organizer every morning. Now, everything we've talked about today is about avoiding dangerous drug combinations. But there's one supplement that millions of older adults take thinking it's harmless, and it interacts with more medications than almost anything else, including blood thinners, blood pressure pills, and diabetes drugs. I made a video that explains exactly what that supplement is and which medications it affects. I'll put it right here on the screen. Go watch that one next, and I'll see you there. This is Dr. Robert Chen, looking out for you.